So let's take a little look at the relationship between violence and culture. And, you know, how do we define culture? Well, that's a little gray. The definition is a little gray. I mean, it really encompasses behaviors, a set of values, attitudes, customs, and traditions in a work environment. It is certainly not the rules, the policy and procedure and written rules. And another way to look at culture is just the way we do work around here. So I think you know what I mean there. We do know, though, that culture, you know, when we have a good safety culture, we see better outcomes and less violence. So let's look at some of these factors that lead to the barriers to implementing effective workplace violence programs, or any safety program for that matter. And this data, this information comes from the research, but also from my own experience over the last 30 years. So as we go through, think about the culture in your facility. Because if you don't know what your organizational culture is at the leadership level, the unit level, and between professionals, it's very hard to know how to design an effective program that's going to stick and be sustainable. So as we've already talked about, you know, if we don't have that leadership style that fosters worker and patient safety, then we have a barrier to effective programs. And, you know, organizational culture can also be defined as the conditions that leaders create and allow. And it occurs at every level, as I said just now, every level in the organization, not just at that senior level, but the unit level and between departments and professions as well. So an idea, you know, an example of poor leadership support would be you report a safety hazard, you're exposed to violence, and nothing is done to prevent that hazard from happening again. There's very poor communication. There's intimidation of staff that might report violence and so on. In a culture that really focuses on patient safety versus worker safety, it's very hard to sustain worker safety programs. So we really have to understand that iceberg picture and look at how everything is interrelated, the patient, the worker safety, and the healthcare organization. And then competing demands, you know, regulation constantly changes. We're dealing with a lot of budgetary challenges post-COVID, staffing challenges, resource challenges, just getting the time and the staffing to allow other staff to attend training in workplace violence prevention is a challenge. Lack of systems approach to services, where you're very siloed. And this again gets back to what I mentioned earlier, that you cannot just address violence or patient violence on its own. It has to be addressing all forms of violence in the context of all other hazards from a systems approach. And then problem solving. If you still see that incidents happen on the job to workers and the workers are being blamed, then you've got a problem there. This is this tells you the culture is not really focusing on that systems approach again. So I go to de-escalate a patient, and I can't do it very well. The patient's escalating. I'm in their room and the patient's standing between me and the door. I try to leave the room. The patient grabs me and injures me. I get bruised on my arm. I get out of the room. I call for help. When my supervisor comes to investigate the injury or the issue, and it could be safety as well, safety folks as well, they tell me that it was my fault. I should have known how to de-escalate that patient. I should have known how to get out of that room and not get trapped between the patient and the door. The better way to look at it would have been, I didn't get the right training in de-escalation. It was over 2 years ago when I got trained. I had no panic alarm within the room, and we were very short-staffed on that shift that day. That would be that systems approach. Give you an idea. I'm going to go through these fairly quickly, but this gets back to the iceberg where I've worked with leadership and they really don't understand the linkage between patient staff safety and workplace violence. So this gets back to what we just discussed with the iceberg. And then again, how does this relate to other programs and patient outcomes? And lastly, of course, our staff turnover issue. This is at C-suite level, mid-management level, direct care staff level, support staff level right now. So when we're dealing with a lot of turnover, it is very hard to implement programs that will be sustainable. Doesn't matter whether it's a patient or worker safety program. The best approach to dealing with this is to have a multifaceted program that's culture-based. So not one person runs the program, it's many people, and it's really integrated into the way we do work so that when we have turnover, the program doesn't die or go away. The barriers to reporting violence then, these have been researched fairly well and are very common across the continuum and the research that I've read. The first is the severity of the incident. So if staff don't get injured, they're not going to report violence. If the patient didn't intentionally hurt me, I'm not going to report violence. So this goes back again to what I said earlier. It doesn't matter about the intent or what you think the intent of the patient was. Violence is violence. It needs to be reported. Whether someone else reports the incident, that's, again, not a clear policy on communication. There's no clear policy about violence prevention. It's a complicated reporting process. I have to go through 10 pages on the intranet to find the report form, and then it takes me 20, 30 minutes to complete. If that's the case, you're not going to do it. Fear of retaliation, and this I've seen in the rural hospitals in the Northwest. There was a nurse in a rural hospital who was assaulted by a patient, and she wanted to file charges. And because it was a small community, everyone knows everyone else, and the patient's family found out who the nurse was and threatened her. So this fear of retaliation could occur internally, or it could be external as well. You have to understand what those barriers are to be able to address them. Poor management response, this is just the way we do work. There's no support for you. I was working with a behavioral health nurse of 20 years of experience. She was nearly strangled one night on the job by a psychotic behavioral health patient. It was just lucky on that shift for her that her coworker was a male that night. Normally she works with a female staff person. So the coworker was able to pull the patient off her, otherwise she would have been strangled to death. She went to the emergency room with a lot of bruising around her neck, and she was allowed to wait there for 4 hours before she got treatment. She then went home and she heard nothing from her employer. I was working with a nurses union at that time, and she came to talk to me about it. And she said, this was traumatic in itself. I nearly died. But the fact my employer didn't care about me, I now want to leave nursing after 20 years. So I think that's sadly a good example of that lack of response and care. Being stigmatized by coworkers. Hey, this is just, suck it up. Violence is the way of the work around here. Get on with it. It happens all the time. Nothing's going to ever happen to stop it. And then poor response by law enforcement and the legal system. And I have a story as an example of that too. This nurse said she was hit in the back of the head by a patient who slammed a door on me as I was walking out the room. I suffered a head hematoma as well as post-traumatic stress disorder now when I hear loud noises. I called the police and they did not respond to take a report. So sadly, do we come to work as healthcare workers and expect to be injured on the job? And I think for most of us, the answer is yes. This doesn't occur in other industries. So we have to change this. I'm not going to read through these in detail, but because violence prevention is new in healthcare, we still don't know all there is to know about what makes an effective program. So we have an inconsistent definition of violence. We have a lack of long-term systematic studies. And we don't have very good standardized, validated tools to assess the risk of violence in patients. And then we may have a need for experts. In smaller hospitals, we don't always have the experts that can do that safety security rounding. So reach out to community partners to do that. Your local law enforcement, your workers' comp insurer, business insurers, sometimes they can provide help with that. And often it's free of charge.